Hello, and welcome back to another episode of the Oncology Brothers podcast. I'm Rohit Gosain, and alongside with my brother and co-host Rahul Gosain. Today, we are here to cover another highlights from San Antonio Breast Cancer Symposium 2024, focusing on three crucial studies. First one being INSEMA trial in hormone receptor positive space, and then switching gears to KEYNOTE-522 study, and then ending off with an update from OlympiA Study. To cover all this, we are joined by Dr. Laura Huppert from UCSF. Laura, it was so good to see you at San Antonio Breast Cancer. Thanks for joining us today.
Wonderful. Thank you so much for having me.
Laura, welcome. Let's dive right into this with our first study, INSEMA Study, which was also published in NEJM shortly after its presentation at SABCS. So this particular study looks into the utility of axillary surgery when compared to axillary lymph node biopsy in early stage breast cancer. Even though our surgery colleagues face this question day in, day out, as a medical oncologist, it is still important for us to appreciate this landscape as well. Laura, can you touch on this study design and its findings?
Sure, of course. So this was a really interesting study presented last week at San Antonio. And the key question is, does every patient need a sentinel lymph node biopsy? And so this trial was a large, over 5,000 patients, randomized non-inferiority study that compared the omission of sentinel lymph node biopsy versus the use of sentinel lymph node biopsy to evaluate whether omitting an axillary surgery compromised invasive disease-free survival. And so, as mentioned, very large study. Patients had to have small tumors, so they had to be T1 or T2 and clinically node negative. And patients were enrolled to either receive the sentinel lymph node biopsy or not, with the primary endpoint being invasive disease-free survival. And at a median follow-up of 6.1 years, what they saw was that there was no statistically significant difference, a 91.7% invasive disease-free survival in patients who received the sentinel lymph node biopsy versus 91.9% in patients who did not. And there was also no difference in overall survival, 96.9 with sentinel lymph node biopsy, 98.2 without. And importantly, they also noted in the presentation and the publication that patients who skipped axillary surgery reported fewer complications, lower rates of lymphedema, better quality of life. So all kind of important, clinical features for our patients that are kind of making this decision. They did see, however, the axillary recurrence was slightly higher in the non-surgery group, about 1%, versus in the patients who received the sentinel lymph node biopsy, 0.3%. And they did kind of comment that these were patients who were undergoing breast conserving surgery, so they were getting radiation anyway. And so there was some thought that the radiation to the breast provided at least some incidental coverage to the axilla, which was kind of a point that was made as well. So I think, what do we do with this data and kind of how do we interpret this data in the current landscape? I think this trial enrolled a very specific patient population. I think they were patients who were 50 years and older, who had a lower risk, profile, smaller tumors, less than 2 centimeters, grade 1 or grade 2. So I think this is the population where you can consider, applying this data. I think some of the caveats, however, I think the 6-year follow-up is pretty good. However, we know that for these smaller, low-grade tumors, these tumors can recur out to 20 years. So we really do need longer follow-up to know if this omission of sentinel lymph node biopsy, the IDFS translates to a longer IDFS benefit with longer follow-up as well. I think the other thing that I thought when I was hearing this data at San Antonio is, now we have the option to use adjuvant CDK4/6 inhibitors in patients who are node positive. And so if a patient forgoes a sentinel lymph node biopsy and they might have actually had a positive sentinel lymph node, are we missing an opportunity to consider treating that patient with, adjuvant ribociclib or adjuvant abemaciclib? I was digging through the New England Journal, about 14% of patients where they did do the sentinel lymph node biopsy in this trial actually had a positive sentinel lymph node. So, about that rate, 10 to 15% who we thought were clinically node negative, in fact, were positive. And that would be a patient that I would, certainly discuss, with the approval of ribociclib now for even small tumors, as long as they're node positive, it is a consideration. And so I think that kind of changes how I look at this data as well a bit. But nonetheless, I do think it's kind of great to have this option for some lower risk patients to consider the omission. I think just some caveats on the length of follow-up and how it impacts adjuvant medical therapy that should also be discussed with our patients before we kind of consider adopting this data.
It's such a fine balance to sort of manage the quality of life aspects, but of course not compromising any of the future outcomes. And as you stated, this was something that was done prior to the era of CDK4/6 inhibitors, and now with ribociclib being utilized in even node negative settings as well. So this definitely changes some of that. And of course, the longer term data will rather dictate where we are moving on. Laura, any portion, like what portion of these patients were rather hormone receptor positive, HER2 positive, and triple negative? And would you think this sort of segment applies to early breast cancer throughout?
Yeah, really good point. So these were all hormone receptor positive, HER2 negative patients. And so I think, I would be hesitant to adopt this across subtypes because it wasn't how it was studied here. And I think even more important for the HER2 positive and triple negative subtypes to know their nodal status because that would dictate their therapy choices as well. So would be cautious there.
Okay. Well, certainly the theme, what we saw from San Antonio and other conferences has been this de-escalation, especially without compromising some of the outcomes here. Moving along into the from early disease to rather triple negative, slightly larger or lymph node involvement, which is KEYNOTE-522, more than 2 centimeter, and node positive disease, where chemo IO has been the standard of care, where perioperative approach of pembrolizumab. However, we all continue to decide which is that population where we can de-escalate rather adjuvant pembrolizumab, or how to decide to who is going to get these 5 medications because they're extremely toxic. At San Antonio, we saw an update from KEYNOTE-522 with regards to biomarker. Laura, your thoughts here?
Yeah, so we've now been using the KEYNOTE-522 regimen for some time with great success. We saw the 5-year update of overall survival at ESMO showing a 4.9% improvement in overall survival using this regimen. I think the key question though is, does everyone need the pembrolizumab? And we'd previously seen the data that regardless of PD-L1 status, pembrolizumab was beneficial, which is why we don't check PD-L1 status before giving this regimen in the early stage. Whereas, of course, in the metastatic setting, it does depend on their PD-L1 status. And so this abstract was basically looking at, are there, we know that PD-L1 is not the answer. Are there other biomarkers that might help us decide who needs pembro versus who doesn't? Because, we don't want to give a medication where the patient is not, allowed benefit, especially with the side effects associated with pembrolizumab. And so this abstract looked at the association between some exploratory biomarkers and PCR, as well as event-free survival in a number of kind of different combinations. And they found that several biomarkers were prognostic but not predictive of benefit with pembrolizumab. And that top graph that you see there shows that they looked at T-cell inflamed and 18-gene expression profile. And they saw that if patients did have this profile that was increased, it was associated with increased rates of PCR and EFS, actually regardless of treatment arm. So whether or not they got pembro or placebo, these patients had higher PCR and higher EFS sort of regardless. Interestingly, TMB, this is a tumor mutational burden, was positively associated with higher PCR and higher EFS in the pembrolizumab arms, but only associated with PCR and not EFS in the placebo arms. So neither of these really seem to be that useful in distinguishing who needs pembro versus who doesn't, but sort of interesting correlations were seen kind of regardless of treatment arm with those. And then the bottom graphs shown there are looking at the associations with molecular subtypes. And they looked at basal-like immune activated, which is on the left. Basal-like immune suppressed is the BLIS on the second one over. LAR is luminal androgen receptor. And then the MES is mesenchymal. And these are basically all the tumor intrinsic molecular subtypes. And the question was, are certain subtypes more likely to benefit from pembro versus not? And you can see on the bar graphs at the bottom, across the subtypes, there were slight differences in response rates by, whether or not someone received Pembro or not. I think the most interesting one is in the luminal androgen receptor. There seemed to be an even more pronounced actually benefit with Pembrolizumab compared to placebo in that group. But sort of regardless, the key takeaway is that across all of these subtypes, there did seem to be a benefit from Pembro, or a kind of indistinguishable difference there. And so I wouldn't use these subtypes to kind of help decide who needs Pembro or not. So I think the bottom line from this abstract is, we did see some interesting trends, but nothing that clearly showed, which patients would benefit from Pembrolizumab versus not. And so there was no clear biomarker identified yet about who needs Pembro in this setting. And so I would continue to use Pembrolizumab kind of across all patients with stage 2 and stage 3 breast cancer who meet criteria per this trial, and not use any specific biomarker to help make that decision at this time.
Absolutely. I think it's important for us to reiterate, those practicing in clinical community settings, there's still no good predictive biomarker, and anyone who falls in this inclusion criteria, KEYNOTE-522 still remains standard of care. Laura, you touched on overall survival. Overall survival benefit was actually a tad bit better in patients who did not achieve pathological complete response versus PCR. That's the other thing that we've talked about. Can we use PCR as our marker? That is also not the case. Your thoughts there, and the KEYNOTE-522 regimen, AC every 3 weeks versus dose-dense AC. What's your practice?
Yeah, both great questions. So it's sort of interesting, previously we thought that if you achieve PCR, that usually translates to EFS benefit. And so we're using PCR as a surrogate marker for EFS. But with longer follow-up in the KEYNOTE-522 trial, one sort of interesting thing that emerged is that even amongst patients who achieved PCR, those who got Pembro actually had slightly better EFS than those who did not get Pembro, even though they both got to PCR, which is a suggestion that maybe there is, EFS or PCR is not the end all be all, that, it is a surrogate biomarker, and maybe Pembro, even beyond PCR, is important to, achieving better, reducing the risk of recurrence, which is ultimately what we care about, right? We want patients to not have recurrence of their triple negative breast cancer. And so suggesting maybe that not all PCRs are equivalent. I think these were sort of small differences, small numbers. I think hard to truly know if that's the case across all trials, but just emphasizes the point, I think, that PCR is a surrogate biomarker that doesn't always equate to equivalent risks of recurrence, which I think is sort of interesting. And then to your second question, dose-dense AC versus not. At UCSF, we do use dose-dense AC, so we give it every 2 weeks and use growth factor to help support our patients. There's a lot of debate about whether you need to use dose-dense or not. There's some suggestion that possibly dose-dense is more efficacious, although I think different trials have seen different outcomes there. But we do tend to use dose-dense. The Pembrolizumab, of course, is still given every 3 weeks, so it doesn't line up quite as nicely. And I think it is important to use growth factor to support patients getting dose-dense to, reduce the risk of neutropenia and febrile neutropenia in particular. But I think that is our practice.
Absolutely. In my practice, when I've used dose-dense AC, I've actually switched Pembro to every 6 weeks, so it lines a little better in that settings.
Yeah,
Laura,
that works too.
Thanks for touching on that. Now let's jump on another standard of care. Use of Olaparib, a PARP inhibitor in BRCA-positive patients. This was approved based off OlympiA Study, and here we have an update on this study. Laura, can you touch on its initial study design and the recent updates?
Yes, absolutely. So the OlympiA trial was a phase 3 double-blind randomized trial that enrolled almost 2,000 patients who had either hormone receptor-positive, HER2 negative, or triple negative breast cancer, as well as a BRCA1 or BRCA2 pathogenic mutation. They also had to have high-risk clinical features as shown here. If they were in the neoadjuvant group for triple negative, they could have a non-PCR. If they were in the ER positive or PR positive HER2 negative group, they had to meet this criteria with CPS plus EG. Honestly, I look it up every single time. It's hard to remember the specific criteria there off the top of your head, but just remembering non-PCR and meeting this high-risk criteria that then you can look up the specifics of. If patients were treated in the adjuvant setting, If they were triple negative, they had to be PT2 or PN1. And if they were ER or PR positive, they had to have 4 or more positive lymph nodes. So basically, high risk patients in either of these groups were randomized 1-to-1 to receive either Olaparib 300 milligrams twice daily for 1 year versus placebo twice daily for 1 year with the primary endpoint of invasive disease-free survival. And this is the updated survival analysis at 6 years. And what we saw is that first looking at the IDFS, there was a 9.4% difference at 6-year IDFS, which is incredibly impressive. And, any drug that's receiving almost a 10% difference in IDFS is definitely absolutely worth giving to our patients. So really important, new advance for our patients to continue giving this drug in the adjuvant setting for those that meet criteria. And then we also saw an overall survival benefit. So this is the updated data at 6 years of 4.4% difference in overall survival, which is actually even more than we'd previously seen the data for 4 years at 3.2, and the curves have only continued to separate with longer follow-up. So now a 4.4% difference at 6 years. So I think this is really a practice-affirming data. We were already using Olaparib in this setting, and I think just even further emphasizes, how efficacious this drug is for our patients with a BRCA1 and BRCA2 mutation. I think, several things that come up with this. I think number one, in the triple negative setting, how do we, how should we combine this with Pembro? Should we do CAPE instead? There's lots of different questions. I think my practice is with the KEYNOTE-522 trial, there was the adjuvant Pembrolizumab given, and we know there's safety data with Pembrolizumab plus Olaparib. And so even though neither study was studied exactly like that, my practice is if I give a patient the KEYNOTE-522 regimen, they do not have a PCR, but they do have a BRCA1 or 2 mutation, I'll do Pembro plus Olaparib in that patient group and not give the capecitabine. If a patient doesn't have a pathogenic BRCA1 or 2 mutation, then I combine capecitabine plus Pembrolizumab. And so you'll kind of have those 2 different options. And I would preferentially use Olaparib for patients with BRCA1 or 2 mutations, given this, impressive benefit in IDFS and the overall survival benefit. I think the data is much stronger than the use of capecitabine. So would certainly preferentially use Olaparib in combination with Pembro for these patients. And then I think for our hormone receptor positive patients that meet criteria, we have the option of CDK4/6 inhibitors as well, right? So ribociclib or abemaciclib, neither of which has yet demonstrated an overall survival benefit, whereas we do have an overall survival benefit here with Olaparib. And so in that setting, I actually also preferentially use Olaparib in combination with endocrine therapy. And I would give 1 year of Olaparib combined with endocrine therapy. And then in the very highest risk patients, I want to do everything I can to reduce their risk of recurrence. I'll sometimes even follow that with, 2 years of Abema or 3 years of Ribo after you're done with the adjuvant Olaparib. I wouldn't combine them, but you can kind of sequentially give one after the other. Again, not studied exactly like that in any particular study, but just trying to do everything we can for our highest risk patients to reduce their risk of recurrence.
Thanks for covering that, Laura. And that's extremely important. That's what our practice has been, at least from community standpoint, combining that is with Pembrolizumab and triple negative breast cancer setting with Olaparib. Just to reiterate the importance of the timeline here, from CREATE-X standpoint, capecitabine is there for 6 months' time. Pembrolizumab from the start of or initiation of therapy, total of 1 year time. Olaparib is 1 year time. When moving into the hormone receptors positive space, we have abemaciclib for 2 years, while Ribo is for 3 years.
Yeah, and I think, Rohit, keeping the dose, keeping this timeline, because this is all shifting and all these new approvals, we have to keep all this in mind. And again, as OlympiA continues to show overall survival benefit, I think the other important part is making sure we offer germline testing for these patients so that they're exposed to these PARP inhibitors. And importantly, these patients and their families get genetic counseling. I think that is very important. Laura, thank you so much for taking the time to walk us through these 3 important studies from SABCS 2024. For our listeners, let us go over a quick recap from today's discussion.
To recap today's discussion with Dr. Laura Huppert from UCSF, we have covered the KEYNOTE-522 update on immunotherapy in triple-negative breast cancer and OlympiA trials insight on adjuvant Olaparib for BRCA patients, and INSEMA study findings on possibly omitting axillary surgery in some breast cancer cases.
Unfortunately, we still do not have a good biomarker in selecting the right patient for KEYNOTE-522, which is our chemoimmunotherapy in peri-op and ongoing post-op immunotherapy. For now, all comers with triple-negative breast cancer that meet the inclusion criteria for this study, this remains the current standard of care. Then the OlympiA trial reiterated the ongoing overall survival benefit from Olaparib in patients with germline BRCA-driven disease. Lastly, as Rohit mentioned, based on INSEMA trial, we can forego axillary surgery in selected early hormone receptor-positive breast cancer patients. Thanks for tuning in. We'll see you in the next episode. We are the Oncology Brothers.